Thank you. And lastly, but not least, we have Dr. Scheirey from, he's the program director at Diagnostic Radiology at Lay Clinic.
Good afternoon, and thank you for having me. My name is Chris Scheirey from the Leahy Clinic. I'm an abdominal radiologist, and for better or worse, I'm a program director. I have no disclosures, and I've been asked to talk to you today about how we use our CT colonography database. And I don't need to talk too much about colon cancer and colon cancer screening. The good and the bad about colon cancer is that it's a preventable disease with proper screening. It's estimated that nearly 60% of all colon and rectal cancer deaths could be prevented with proper screening. Unfortunately, nearly 40 million adults in the United States are not screened properly. And why is that? The Colon Cancer Screening Alliance sent out a survey to patients in 2011 asking them why they're not getting screened. And it's interesting because CT colonography, for those of you who aren't too familiar with it or who aren't doing it at your institutions, can help with that. Patients who are too busy or have too many time constraints, you can do a CT colonography without any sedation as opposed to an optical colonoscopy. Fear of the examination, fear of an optical colonoscopy, healthcare insurance and co-payments and other things. So that's what CT colonography is used for. CT colonography can help in preventing colon cancer. The original Sentinel article actually came out in 2003 from Perry Pickert. There have been several articles since showing that CT colonography has excellent sensitivity and specificity for detecting polyps, which can develop into colon cancer. One of the largest trials is actually sponsored by the American College of Radiology and was published back in 2008. And because of all these articles, the American Cancer Society adopted CT colonography as one of its recommended screening tools for colon cancer. And I added a picture here of President Barack Obama, and many of you in the room probably know that he was screened with CT colonography, taking advantage of one of the benefits of CT colonography that you don't need sedation, so he didn't have to transfer powers. So CT colonography can help in screening patients. Unfortunately, it's only being reimbursed in 22 states. One of those is Massachusetts. So, and it is not covered by CMS. And that's one of the issues with the CT colonography database in general, is that there's a small number of institutions enrolled in it. In part because there's a small number of patients that are getting screened with it, in spite of the fact that we have all of this research showing that it's a good screening tool. So I'm going to use this as a plug for all the radiologists in the room, any legislators in the room, to support the American College of Radiology in their support of CT colonography and trying to get widespread reimbursement. So what is CT colonography? For those of you, I'm going to presume that some of you aren't too familiar with it. It's also known as virtual colonoscopy, virtual colonography, or CT colonoscopy. How it works, it's essentially a very subspecialized CT examination. So patients have an oral preparation to cleanse the colon, similar to what you would get for an optical colonoscopy. We have to bring the patients in after they've been prepped. We have to distend the colon. We put a small Foley catheter into the rectum. We use a CO2 insufflator to distend out the colon. We use low radiation CT images. We have to scan the patients in at least two positions to make sure the colon is adequately distended and seen. And then obviously we have to go through and interpret our studies, generate our report, and follow up. So each one of these steps actually has its own issues. If you don't follow and watch your prep closely and make sure patients are taking it appropriately, you're going to have skewed sensitivities and specificities for picking up polyps. If the colon is not well insufflated or distended, and there's certain areas of the colon you're just not going to be able to see very well. And then we need to make sure that we are actually interpreting the studies appropriately. So are we seeing all those polyps that we need to see? This is an image from an article published by Perry Pickert, but it just kind of shows the top right image is the axial CT image, and the two left images are the 3D colonography software that we use. And you can compare that to the image on the bottom right, which is actually an image from the optical colonoscopy in this particular patient. Just kind of shows how good the images are from CT colonography and what you can see. So the NRDR, and what are they doing? So they have 6 different measures that they're looking at. 3 of them are process measures, 3 of them are outcome measures. The one that we were particularly interested in is the adequacy of our bowel cleansing and distension. It's also looking at the adequacy of your diagnostic and screening examinations. So the diagnostic examinations are those patients who are symptomatic. Screening examinations, obviously patients who are asymptomatic and just getting screened. And then looking at the outcome measures, so the rates of colon perforation, your true positive rates, and then looking at all the extracolonic findings. So anytime you do a CT colonography, you have to look at everything else in the abdomen. You have to look at the liver, the pancreas, the kidneys. So Leahy Clinic CTC, what are we doing? So we actually first started doing CT colonography back in 2003. We have a small number of cases compared to our practice. We perform about 1,200 CT scans a week, and our CT colonography volume is about 50 to 100 per year. There's a small number of readers, and that's me. So I have nothing to compare to. I don't have any other radiologists in the group that I can compare my sensitivity and specificity and ability to pick up these polyps. And currently there's no national standards, and in particular, there's no number of incomplete or suboptimal cases. Most of our volume comes from incomplete colonoscopies. I've actually convinced our administration, even if we don't get reimbursed for it, any patient that has an optical colonoscopy that's incomplete that day, we bring the patient back down that afternoon, and we do our CT colonography. It's not always reimbursed, but it's the appropriate thing to do for patients. But there's no standards as to what's optimal, how many is suboptimal is okay. There are certain patients, regardless of what you do, you're not going to be able to see the entire colon very well. Patients who have prior surgeries, hernias, strictures, for whatever reason, you're just not going to be able to see those patients' portions of the colon very well. And there's no set standards as to the number of true positives that you should see. So we decided to join the NRDR back in 2010. And this is the first report that we got. You can see here it lists on the left-hand side all of the different measures, and then it's comparing Leahy Clinic to all the other facilities. This was the area that I was most concerned with, was the adequate bowel cleansing and distension. And as our coordinator can attest to, this is what I looked like when I first got our results. And even though it's a small number of cases that we did at that point in time, you can see we were definitely off of the national average and what we should be doing. Prior to joining the NRDR, as I said before, most of our cases were incomplete optical colonoscopies. I kind of presumed that we were doing everything okay. Our program had actually been started when I was a resident, so I presumed everything was going okay at that point in time. So this was kind of an eye-opener to me. Just to kind of give you a sense, this is an image that was actually obtained from a patient during that time span. And it's kind of hard to see, but that top left image is a supine image, and there's a little polyp at the end of the arrow. The image below that is from the prone data set, and you can't find it. It's because the colon's not well distended. If you actually look at the rest of the colon on the left side of the screen there, you can see that the colon's not well distended. On the right-hand side of the screen, you see another polyp. It's kind of coated in a little bit of contrast. That one you could pick out on the prone image below. So we referred this patient to get an optical colonoscopy. We said we found 2 polyps. So they had their optical colonoscopy. We were right on both of those, but we missed 3 others, in part because of the colon not being well distended. And this is just another image from another patient that time frame. And you can see the top left image shows supine acquisition. That's a well-distended colon. That's what you like to see. You can see a little polyp at the end of the arrow there. The image below that is a prone image. So the patients are lying on their stomach. The colon's not well distended. Couldn't find it in there, but I was convinced enough that that was a polyp, and it turned out to be a true polyp. Nevertheless, you can see that there were issues going on. So what did we do? We essentially created a quality improvement project. I went back and reviewed all the current literature, all the best practices, did an in-service to all the technologists, made a PowerPoint presentation discussing with them pitfalls, imaging parameters. My particular concern going back at and looking at our data from the NRDR was that our primary issue was distension of the colon. So we actually brought in the rep for our CO2 insufflator, and discussed with our technologists what the best way is to distend the colon. If it's suboptimally distended, what are some tips and tricks you could do to make sure that it's appropriately distended. And we changed our practice patterns, and we made sure that no patient left the department without being checked by a radiologist for accuracy and adequacy. Prior to that, the techs, if they thought there was an issue, they would give us a call. Otherwise, they would send the patient on. So I know the formal QI project is supposed to wait however many months, a year and a half. Nevertheless, we made some immediate changes to what we were doing based on the feedback from our first data set, and you can see we showed an immediate improvement, even though I actually did this presentation to the techs in, I think it was like in August of that year, so actually in August of 2010, in the midst of acquiring this data. And so thumbs up to all the technologists to make sure we were doing appropriate examinations. And then what do we do after that? So we decided to take the NRDR quality improvement project one step further. So we created at that time our own database. Prior to that, any positive virtual colonoscopies that I was doing, I would kind of keep note of and follow up. But we weren't really keeping close track as to the number of suboptimal studies and everything else. So we made a fairly rigorous database, and we're looking at polyps 6 millimeters or greater in size now. It used to be, and the NRDR is actually just looking at larger polyps, 1 centimeter or greater in size. And the data there isn't all that important, but it is interesting to note I actually had a conversation with one of our endoscopists this week, and I told him, hey, look, there's a 6 millimeter polyp in the cecum. I know that the patient has some issues and had some pain during their optical colonoscopy, but it looks like a real finding. And she said, oh, really? Is it really that polyp there? And I can go back to the data and I can say, well, everybody that's had an optical colonoscopy, we've had 17 true positives and only 1 false positive. This is a polyp the patient needs to get screened. And she was actually reassured by that data and was reassured by the number of positive cases that we have is actually totally in line with what they're doing in the endoscopy suite. So I've convinced one of our endoscopists, who was already sending patients down with incomplete colonoscopies, but she's in line with what we're doing. And then I, took it one step further. As program director, I'm trying to involve the residents and getting them more involved in quality improvement projects. So we actually did the same thing that the NRDR is looking at in terms of distension, and we kind of carried it over and created our own quality improvement project with CT enterography. Again, that's kind of a specialized small bowel examination. We have similar issues, and we have to make sure that the patients are drinking the oral contrast agent in the appropriate time frame, and making sure that the small bowel is adequately distended. We reviewed 6 months worth of data for our CT enterography cases, kind of graded them on a scale of 1 to 5. And what we realized is that patients, and I kind of knew that going in, that we had a fairly high rate of suboptimally distended small bowel studies. So did the same thing, reviewed the literature, actually had the resident do this, review the literature, created a PowerPoint presentation, went to the technologists at our 2 different sites, spoke to them about what the best way is to do the studies, making sure that the patients are drinking when they're supposed to drink and the patient's getting scanned when they're supposed to be scanned. Anecdotally, I can tell you that we're significantly improved compared with what we were a year ago. We haven't actually officially reviewed that data, but it's a very powerful tool. So in conclusion, colon cancer, it's a big issue in the United States. CT colonography definitely has the potential to increase the number of screened patients. And for those of you who aren't sure about CT colonography, what it's used for, there's actually a study from the University of Wisconsin comparing 2 groups of patients who have had optical colonoscopy. They opened up the screening center, and it shows that they're bringing patients into the fold, patients who aren't getting screened, patients who are afraid of an examination or say they don't have time. So you can really increase the number of patients that get their colon cancer screening. And that the NRDR is extremely useful in adjusting our own practice patterns and setting some of the national standards and baselines. It's also a great tool to kind of get a sense for other projects that you can do in your department to improve patient care. So thank you very much for your time.